Hello guys, I hope you're well. So as you can see on the BNF, it says the choice of ACE inhibitor depends on comorbidities and other sort of details about the patient. And this is very, very crucial because when we look at the hypertension guidelines, which we'll go over in another video, a crucial point is the ethnic group of the patient because for some ethnicities, according to the hypertension by NICE, you should give a CCB instead. Now, why? Because genetically, some patients are able to produce more renin naturally, thus leading to a higher blood pressure. For example, in type 2 diabetes, a patient of South Asian origin may be more genetically predisposed to get type 2 diabetes. So this is important to take into account for exam purposes as well. Now, let's go to NICE guidelines for ACE inhibitors. As we've gone through earlier, we've talked about pregnancy. And as you can see, it says use of ACE inhibitors is contraindicated in pregnant women and those planning a pregnancy due to risks to the fetus. Now, as I look at this sort of reminds me of nitrofurantoin, which is given for UTI. Now, why does that remind me of nitrofurantoin? I'll tell you guys. Nitrofurantoin is contraindicated at term, so third trimester, due to neonatal hemolysis, which is also seen with sulfasalazine, which is a DMARD given for ulcerative colitis. So keep that in mind, guys, when you're revising. Now it says breast, breastfeeding women, ACE inhibitors are not recommended as there is limited information on their safety. As we go down, as we've gone through taking diuretics, you should know by now that different diuretics have different effects on potassium levels. Potassium-sparing diuretics such as spironolactone can increase potassium. Loop diuretics and thiazide-like diuretics can decrease potassium. And if you have any drug that can cause hypokalemia, then it can exacerbate digoxin toxicity, which is a drug used in atrial fibrillation or different types of arrhythmias, which are abnormal heart rhythms. Now, as we go down, we can see some ADRs that we've been through on the channel, such as hyperkalemia, which is increased potassium, cough, and as you can see here, it says cough is reported to occur in 4 to 35% of people taking an ACE inhibitor and may occur at any time after starting treatment. Now, a crucial part on the board is it says if the cough is troublesome, for example, it prevents the patient from sleeping, and other causes have been ruled out, consider switching to an ARB. So this is a crucial point when revising, because if you have a patient that has cough, especially in the scenario, if it says it's preventing the patient from sleeping or it's annoying the patient, then you would switch from Ramipril to, for example, losartan. Keep that in mind. As we go down, we look at angioedema, and obviously angioedema is defined as a non-allergic drug reaction, which can precipitate angioedema. So what would you do if you get angioedema for a patient? You would stop ACE inhibitor treatment immediately and consider starting an alternative drug treatment. Now here we have to pause, guys. By alternative, an angiotensin receptor blocker can still cause angioedema as it affects the renin-angiotensin-aldosterone system. So it's preferred to switch to a calcium channel blocker. As you can see here, if possible, avoid angiotensin 2 receptor blockers as these can also trigger episodes of angioedema. And that's it for now, guys. Thank you so much.